just for any newcomers, we are recording. Please introduce yourselves and pop any questions in the chat, and we will try our best to get to some questions at the end. So for anybody new to us, it looks like there are quite a few new people. We're the South West Learning Disabilities Collaborative. Everybody's welcome wherever you're based. We are going to share these slides afterwards, so you'll have this information slide, and please feel free to sign up to our collaborative and our newsletter. We have a really packed hour ahead of us. It's going to be fantastic. So we've got some great speakers and lots of topics to cover. Just to say, we've got some really great videos that we're going to try our very best to share. We have done the tech checks, everything looks okay, but you never know whether we get gremlins, so apologies in advance if we have any technical glitches, and we will be able to share anything afterwards that if we have any issues along the way. So with that said, I'm going to hand back to Alison and to Laura to start us off.
Thanks very much, Susie. I don't seem to have the slides. Can other people see the slides? Unless it's up. I've got them now. Apologies. So for people who just been joining, I'm Alison Tavray. I'm a GP by background, and I co-lead the South West Learning Disability Collaborative. And in a minute, I'll just give you a quick overview slide, then I'll pass over to my colleague Laura. So next slide, please. So really, as a doctor, I just wanted to say we tend to concentrate on the medical management of constipation, and this is a journal article written by headed up by the team in Cornwall, and it's all about the medicines and how to prescribe for constipation. It's great, but that's not the emphasis today. We want to look at the non-medical management. We will share this resource afterwards, but this is the medicine bit, and we don't want to concentrate on medicine today. We want to look at the other approaches. So with that proviso, I'm going to hand over to my colleague, Laura.
Hi, I'm Laura Canning. So I am currently on secondment with NHS England, and I'm the Health Inequalities Lead for the Learning Disability and Autism Programme. But professionally, I'm a physiotherapist. My experience typically is with those with profound learning disability and within 24-hour postural management. So I'm really pleased to welcome the speakers that we've got today and have a more holistic view of constipation. I've just got this one slide really just to introduce kind of why we're discussing this today and to bring some context. So in terms of not just constipation, but good bowel management and why it's important, obviously as clinicians and people who support people with a learning disability and for people with a learning disability themselves, we're trying to promote good bowel management to facilitate good physical and mental health. We want to identify, detect constipation and any changes early, rule out any red flags, and we know that those with a learning disability are significantly more likely to be prescribed a regular laxative than when compared with the general population. Obviously, there are lots of factors that are going to increase this risk. Those who live in a residential home, those with kind of postural changes, complex disability, dysphagia, challenges managing nutrition, but as clinicians and people supporting and working with learning disabilities, we may see that present in a number of different ways in terms of pain, changes in behaviour, and the purpose of this event is really to discuss and think about that in a really well-rounded way. So with that in mind, I will hand over to the first presenter, and we have Tracy and Mark with us.
Hello, I am Mark.
Hello, I'm Tracy, and you'll meet Sean later in the presentation. We're here to tell you about our proactive and creative approach to a subject that many people find difficult to talk about. Next slide, please. Constipation remains a big problem for people with a learning disability and/or autism. There are many barriers and challenges both for an individual and those who provide care and support.
We are proud of our poo project and want to tell you about it.
And Susie, before that slide, could we go back and play the, we're now going to play the 5-minute introductory presentation slide.
Yes.
Okay, if we can go to the slide that you had, that's the one. Lovely, thank you. So the diagnostic criteria shown here on the left is widely used. Less known is how this can present, which depends on what the person may know and understand, what they feel and think about poo, and messages they get from others. Everyone is individual, and any signs will differ from one person to the next.
We need to get better to talking about poo and spotting the signs.
Next slide, thank you. These next 4 slides show some possible signs, but really any change will be important. Good monitoring and review should help to show changes. Next slide. Next slide.
A long time to the loo, a fear of pain when you poo. We all poo when you in bed or the bath, not sleeping well, not going out and may stay in bed, tight clothes can make pain bad.
And although some people may expect someone to stop or reduce their eating and drinking, some people may continue to eat and drink as normal, which is really important to know. Next slide, please. So on the next slide, which is change in behaviour, a new behaviour or an increase in the frequency or intensity of known behaviours, increased anxiety or resistant behaviour. There may be new or worsening incontinence. Somebody might show with poo under their nails, or that's found in or on their clothes, or it might be wiped on curtains or towels, for example. Mood changes are likely to differ for each person and again may not present as is expected. Next slide, please.
Bad sign, bad skin and headache, back pain, on leg cramp, feeling tired, not wanting to sit down or move.
And it's important to know that not everyone will show guarding, which is the voluntary or involuntary tensing of abdominal mass when having a examination. Sorry, lost my words then for a minute. So when being examined. Next slide, please.
Constipation is not normal or okay. It may cause other changes. Know why we may not tell you. Check out what is not right.
Absolutely. Next slide, please. So everyone has a role to play and we need to work better together. Health professionals rely on clear information to decide on action to take. It may be assumed that a carer has more knowledge than they actually do. What do you know and where can you get more information and support? You have a role to educate and encourage people to talk about poo, and language and communication is always key. Have a think about what are your views on poo and how this can affect people you talk to. You need to know a person's usual baseline, but always remember usual may not be normal. Next slide, please. So something to think about. Are you monitoring? And if not, why not? The person may not want you in the bathroom with them, but does that mean that they know how to recognise or report a problem? You may need to be creative in your approach to make sure that a person is safe. Next slide, please. So as a team, is there a team approach to monitoring and what action to take? Has a capacity assessment been carried out? Is there a care plan and risk assessment in place? Raise any questions or concerns that you may have and inform professionals by sharing what is usual for a person and any changes from that. Next slide, please. So the role of health professionals.
Listen to me, find out what I know, the words I know, pictures can help me.
Lovely. Next slide, please. So medication can be needed, but should be reviewed and used alongside and not instead of lifestyle changes. Next slide. So our project was called Poo Matters because we used information that was already available at the time. We are changing to flushed with success. This still refers to having a good poo, but as the definition here shows, it also says how we feel about our progress so far. Next slide, please.
Sean will now tell you more about our work.
You can play Sean's little video clip, please, now.
Hi, I'm Sean, and I'm sorry I cannot be with you today. I want to share with you my experience and some of the work we have been doing. It started when Tracy sent questions to People First members asking about their experience of constipation, what they knew about the subject, and if they wanted to learn more. Mark and I, with a few others, were happy to meet. Because of COVID-19, we had to meet on Zoom calls for the first 6 months. The group talked about words that are often used and agreed to use the word poo for our project. Before the project, I thought the word feces related to dog poo. I did not know it was also used for people's poo. He shared how he felt talking about poo and looked at some easy read leaflets. The words and pictures did not always match. It was confusing. As a group, we agreed that was important to share with others. Through lockdown, Mark and I were able to form a bubble, and we tested recipes that are better for our bowel health. He scored on the taste and how easy they were to make. I am now more aware about what I eat and drink. Before working on the project, I did not know it could be such a problem. Sometimes I did not poo for a couple of weeks. I assumed I was not going to the toilet because I hadn't eaten enough. I now go every morning and I feel awesome after I've had a poo. I did not feel able to talk to anyone about my health. Because of the project, I have felt able to speak to people I trusted about my fear of the dentist, and I was helped to get the right support and had treatment for the first time in 40 years. I had also been sent the bowel screening kit every year for 5 years, but threw it away as I did not understand and it scared me. During the project, I was sent another one. This time I did the test and sent it off. The letter came back to say all is okay. Poo Matters really helped me understand why it's important to talk about poo. Over the last couple of years, we have talked to a lot of people with a learning disability, and over 70 have told us what they think. Like us, a lot of them found it embarrassing to talk about poo, not always knowing what could help if they had a problem, but over half of them wanted to learn more or wanted the people supporting them to understand how to support them better. Mark and I are often asked about the poo project at People First groups. I really think that we need to have positive conversations about poo from an early age to make it normal to talk about it and a health way. It can sometimes be difficult getting carers and professionals to realise the difference our work could make. Sharing the knowledge with other people is important, and I love it when people show an interest and ask questions. Knowledge is power, and it can stop other problems, and it could save lives.
Right, next slide, please. Okay, so in the workshops, we wanted to increase knowledge by exploring the barriers and finding solutions.
We had a lot of fun and finding out what could help.
The sweet corn challenge can tell you how long food takes to become poo.
Some of us did not look at our poo before this.
Next slide, please.
Denise said it is important to talk about poo so she does not get unwell with tummy ache.
Next slide. Not having a poo gave Becky headaches, made her feel uncomfortable and moody.
Becky said, go when you need to, make sure you have lots of toilet paper.
Next slide. Andy learnt he had a problem and needed help.
Andy said, talk to someone you trust. Carer needs to know how to support you better.
Next slide. Lizzie had bad headaches, and would strain to get the poo out. So I'm going to cover Mark's bit for a minute. Lizzie said, I know to drink more. Next slide. So C, as it says here, C is not just for constipation. If we want to make a difference, we need to change our views on constipation, how we talk about it and how we support people to manage it. And Mark would normally say here, what is usual may not be normal, and that is really important to remember. So next slide. And on behalf of Mark, I will say thank you for listening.
Thank you, Tracy. That was fantastic. We've got quite a few questions which we'll perhaps try and answer at the end, but it's given me loads of insight, and particularly Sean and Mark both saying we need to talk about poo and we need to be much more open on that. And perhaps something you might be able to answer in the chat is that somebody's saying, how can we raise awareness of people talking about poo so we can start these conversations? And I've seen someone's put their hand up. I'm afraid we're a bit aware of time. So what I might do is pass over to Ruksana and hopefully have a bit of time at the end. But thank you for that fantastic presentation. And Mark and Sean particularly, we really appreciate all they've done. A lot of preparation's gone into that today. So I'm now going to pass over to Ruksana, who's a specialist physiotherapist working in learning disability, and I'll leave Ruksana to give a little bit more information as to why she's such an expert. Thanks, Ruksana, coming down from London to do this for us.
Okay. Right. Thank you for having me today. Thank you. Can you hear me? Yeah. Okay.
Yeah.
Thank you, Alison, Tracy, and Mark. So a little bit about myself. I'm a learning disability physiotherapist by background. I'm also a very proud carer for my brother, who has profound and multiple learning disabilities, complex physical disability, and constipation. I've also developed something called a community of practice, which helps to train healthcare professionals around the UK in abdominal massage for constipation, as there was a need for an established sort of trainer in the UK. So that's me in a nutshell. I hope to provide you with some invaluable insights, some practical advice, and to share awareness on the total bowel management approach with a focus on the non-pharmacological treatments, including abdominal massage for constipation for people with a learning disability. Okay, so this picture was taken from a study. It was with multiple sclerosis, MS population involving abdominal massage for constipation. And this particular participant was able to say this particular statement regarding constipation. Sometimes, even if I stand in the middle of the room, no one acknowledges me. Constipation can be the elephant in the room. It has huge, significant effects on quality of life, but it is still seen as a taboo subject. We all need to get comfortable talking about constipation, opening bowels, or poo as part of health promotion and positive health management. It should not be a taboo topic. It is a normal bodily function for survival and well-being. As we have seen from Tracy and Mark's slides, that most people with a learning disability, they do come under 3 categories of constipation. That's primary, having lifestyle factors; secondary, having a medical condition, such as cerebral palsy, and iatrogenic, which is having side effects of medications. So yeah, next slide. I'm going to go on to a few case examples. So case A is a gentleman with autism, mobile, active, 30 years old. This is a case study from about 20-30 years ago now. He was on a cocktail of laxatives, including sodium picosulfate and regular enemas. He hated the mess the enemas would cause, was very embarrassed. So he began refusing the enemas. I'm sure we could all understand that, putting ourselves in his shoes. So his constipation worsened, his physical and mental health deteriorated, and he unfortunately lost his day placement due to aggressive behaviours or behaviours that challenge. As an emergency, a 3-month respite placement was put in place. A total bowel management programme was introduced by the community team for people with learning disabilities in his area, which included abdominal massage for constipation twice a day for 15 minutes. After gradually through a 3-month period, he had regular type 4 poos. He had a monitoring and escalation plan in place, occasional laxatives. No enemas were needed, and he was able to return to his day centre. So positive case study of when implementation of a total bowel management programme, including abdominal massage. And as far as I know, this gentleman is still happy and living his life. He was actually going towards dying from constipation. They had to use a tape measure for his abdominal circumference as a sort of another objective outcome measure. He would present with extreme bloating. So that was a clear outcome measure for this gentleman. Case B, it's a 20-year-old gentleman with PMLD, physical disability, and is peg fed. He was on Movicol, sodium picosulfate, and regular bisacodal suppositories to medically manage his constipation. In 2019, he had a HDU admission for pseudo-obstruction due to constipation, and they were querying aspiration pneumonia. Now, the reason I would like to mention this is sometimes when a person with a learning disability gets to hospital, the focus is on the chest. Is it and treating with antibiotics, and sometimes they don't always see what might be causing the chest issue, and it's actually coming from lower down in the tummy. So after this hospital admission and rightly treated acutely with laxatives and medical management, a total bowel management program was introduced. So standing frame 3 to 5 times a week, hydrotherapy, abdominal massage for constipation. Laxatives were then able to be reduced, and this particular person is on sort of a liquid diet, a peg feed diet, so their stools were more on the type 6-7 was actually normal for this client. So abdominal massage for constipation had a positive effect. Air was also passed out of the peg during the massage, which you can see through bubbles coming out of the button, or air was passed out of the bottom, or even poo passed during or soon after the abdominal massage for constipation. I've mentioned air here because I'm sure we've all experienced that abdominal gas can be extremely painful, and it's another symptom of constipation that we do need to take into consideration. Movement and abdominal massage is something that can help not only with the movement of poo, but also the movement of painful abdominal gas. Later, sitting on a commode each morning was introduced, and 90% of the time this has resulted in doing a poo or air being passed. So yeah, over the years, managed at home and prevented hospital admissions due to a total bowel management monitoring and abdominal distension plan in place. So 2 very positive case studies there. I'd just like to mention one last thing, is that bloating can cause an increase in respiratory secretions and work of breathing and discomfort, and that can cause seizures in particularly more complex excuse me, people with a learning disability that also have complex health issues. Okay, so NHS England released some constipation resources for people with learning disability. They state that constipation can be a life-threatening issue for people with a learning disability who are at heightened risk from complications if left untreated. 23% of people with a learning disability who died in 2019 had constipation as a long-term condition. And as mentioned in the previous presentation, people with a learning disability may also be less likely to recognize the symptoms of constipation and be able to communicate their symptoms, increasing the risk of serious consequences. And that's why the involvement, the detection of constipation symptoms for that individual is so important, and that involves the care network. Really crucial. That's us and anyone involved, professionals and carers. Next slide, please. Really important national guidance here. So Public Health England released a set of resources for people with a learning disability in 2016. They stated that constipation is a significant problem for people with a learning disability that impacts their health and quality of life. They stated that their recommendation is that there's a need for a total bowel management approach, which includes abdominal massage delivered by a multidisciplinary team with physiotherapy as an integral part. This can improve the health outcomes for people with a learning disability, as well as having potential cost savings for the NHS. They've stated that abdominal massage can be as effective as laxatives in the treatment of constipation, which is a huge statement. And total bowel management can be time consuming, but can help to improve the bowel habits of people with a learning disability and can lead to a reduction or stopping of laxatives. Just to mention here, stopping the over medication of people with a learning disability, autism, or both. Although this is more specific to psychotropic medications, it is still a good reminder in the case of constipation that laxative use can also be reduced or stopped with the addition of total bowel management and abdominal massage. Okay, so medications that increase the chance of constipation: pain relief, mental health, mood medications, heart medications, kidney medications, medications for spasticity, muscle relaxants. So antacids are then an example of that is Gaviscon. Who knew Gaviscon, a side effect is constipation? Antihistamines, iron supplements, Parkinson's medications, and seizure medications. So they all have an effect on the nerve and muscle activity in the large intestine, and this can result in slow or difficulty in passing stools. The reason we need to know this is that these are probably important medications that people with a learning disability need to continue taking, which is why we need to focus. Obviously, the medical review is really important to know if they're on the right dosage and if they still need them. However, we need to focus on the non-pharmacological aspects of improving constipation, as some of these medications are crucial for managing other health conditions. Next slide, please. Adverse effects of constipation to be aware of. Some you probably know are really obvious and some not so much. Abdominal pain, discomfort, pain on attempting to poo, loss of appetite, increased tiredness, increase in reflux, emotional irritation, increase in behaviors that challenge, effects on the respiratory system, which I just touched on. But if you imagine the stomach, the large intestine is quite full with poo, it then presses on the diaphragm, which then presses up on your lungs, and it just makes it harder and more uncomfortable to breathe as well. And the communication of that might not be verbal for our people with a learning disability who are non-verbal or can't communicate as clearly. So that's why we need to be looking at objective measures such as respiratory rate, such as work of breathing, such as facial expressions, such as body language. And that's where the people that know the person well, that see them on a daily basis, are key to noticing and reporting to healthcare professionals, which also requires training. So I'm not putting it all on one particular individual at all. There's work to be done for everyone. Seizures, overflow diarrhea, and more seriously, bowel obstruction, fecal impaction, and bowel perforation. Okay. How do we assess bowel movements and identify constipation? Using the Bristol stool chart. And what we like to do is to compare results of the average bowel movement patterns and the definition of constipation to a person, to their usual, and compare that to see if it comes in within the definition, or if it doesn't, then work needs to be done to help to improve that. Again, I'll just leave that there for your information later when to refer to the GP. Okay, here's a next slide, please. Just a quick example of a Bristol stool chart and how maybe to complete one. So a tick for if someone's passed, and then documenting if it's small, medium, or large. And this particular example does show that on Tuesday and Friday, type 1 stools, a small, medium amount, and then on Saturday, type 7 stools. So this would suggest overflow diarrhea, and this would need to be reported to the GP for laxative and medical management. Okay, next slide, please. Okay, so the total bowel management, as recommended by Public Health England, consists of both pharmacological or medical interventions, as laxatives in simple terms, and non-pharmacological interventions. The non-pharmacological involve diet, fluid intake, mobility and exercise, toilet positioning, social and psychological factors, and toileting routine and abdominal massage. For diet in particular, we do, if someone doesn't have any particular requirements, we advise the Eat Well guide by Public Health England. But if someone is sort of tube fed, peg fed, and G fed, definitely the dietitian needs to be involved with any sort of diet review or improvement. For fluid intake, it's recommended to have at least 30 mils per kilogram. So that gives you a bit more specific to the person's weight of how much hydration at a minimum we should be aiming for. Okay, next slide, please. So for mobility and exercise, so a lack of exercise slows the natural movement of poo in the bowel and can lead to constipation. It's clear evidence that adults with learning disabilities have low levels of activity in comparison to the general population. Those with higher levels of disability and those living in more restrictive environments are an increased risk of sedentary lifestyles. In relation to good bowel health, even just moving around is good exercise. An extra walk a day is good exercise and can help to get the abdominal muscles to work. We don't think that a walk will benefit our abdominal or digestive muscles, but it does. Okay. So incorporating and increasing mobility and exercise sorry, just go back one slide. I just, thank you. Into the person's activities of daily living also helps with movement of stools in the bowels. So where a person is able, we encourage walking. Where a person is not able and it's assessed to be appropriate, they should be supported with regular position changes, standing frames, movement or stretching programs, and any other activities such as hydrotherapy and rebound therapy. Okay, next slide, please. So there's an optimum positioning for opening bowels, and as you can see, it involves the knees being higher than the hips. As you know, the majority of the world's population still squats today to use the toilet, if you're aware of Eastern toilets. So the colon is naturally kinked to allow for continence when we're standing and sitting. So having the knees slightly more raised ensures a straighter passage for poo to come out of the rectum and the anus. So the optimum position involves leaning forwards, leaning onto the knees. So we should try and support our clients into this position as much as possible. Another reason is that just incorporating a small footrest that allows the knees above the hips actually reduces the amount of sitting time required on the toilet. Also, if a client has a complex physical disability, they may require a more specialist toilet seat, such as a tilt-in-space commode or a specialist commode for toileting. Some clients may not have this option in place already, and it would be recommended to explore and consider toileting position and routine to improve their bowel habits. And this is usually with the involvement of the occupational therapist. Yeah, that's it for that one. Okay, so the approach also involves addressing social and psychological factors such as embarrassment, social isolation, and anxiety. Long-term constipation is associated with urinary and fecal incontinence, which in turn can increase social anxiety. Just involving discussion and reassurance for the person with a learning disability or seeking further support from other healthcare professionals can help address this. Just touching on toileting routine, having a specific time during the day where a person is supported to use the toilet is really helpful with sort of training the body and the bowels, where this is my time to open bowels. And usually that is first thing in the morning after resting and digesting throughout the night, or approximately 30 minutes after having a meal. Okay, and I'm not going to go into laxatives, but there's a bunch of the common ones on the side there. So what is abdominal massage? I think that's the reason why most of you are here today. It's a technique, a massage technique using particular strokes, effleurage, which is sort of a medium pressure flow, a kneading technique. So imagine you're kneading bread like this, if you can see my hand, and you imagine there's a Malteser underneath your palm. You're sort of kneading around like this, and then sort of a vibration over the stomach on the end. It's applied to the abdominal wall, so it's external, following the presumed course of the large intestine to reinforce the gastrocolic reflex. If you look at the arrows, so the arrow going up is the ascending colon, and the arrow going across is the transverse colon, and the arrow going down is the descending colon. So this is where we do most of the work, applying the massage and encouraging the poo to move along the large intestine. There's a short warm-up sequence just before, and there's a short winding down sequence. The reason for this is so that the person with a learning disability or autism has clear cues that the massage is starting and that it's ending. One of the theories for how abdominal massage works is that it stimulates a process called peristalsis, or the gastrocolic reflex. So when we eat something and it starts contraction and relaxation down our food pipe or esophagus, we're actually trying to stimulate that on the stomach. So by applying the massage, we're hoping to stimulate contraction and relaxation of the muscles in the large intestine and digestive muscles. Next slide, please. Benefits of abdominal massage: non-invasive approach, it's external, it's a pleasant experience, low risk, cost effective, and there's further benefits there that I'll leave for you to read after the webinar. Next slide, please. Abdominal massage improves quality of life, reduces laxative use, and improves frequency and consistency of bowel movements. Can be carried out by parents or carers who receive the appropriate training and support from healthcare professionals competent in abdominal massage. It enhances communication and relationships, along with the relief of symptoms associated with chronic constipation. So I'm just going to, if you can play at this short video, you should hear some sounds of stool moving or poo moving along the descending colon. Okay, thank you. Next slide, please. So I'd just like to share a little bit, finally, on my brother's total bowel management. So you have a bit of a working template. So he has 24-hour carers at home. So the stool chart is completed daily. Frequency, consistency, and approximate size of stools is documented. So clear monitoring charts are in place. For hydration and diet, we have the community LD dietitian involved, ensuring adequate hydration via PEG, adequate nutrition via PEG, and you might be interested to know that we also give my brother a blended homemade feed for 1 meal a day. So that's loads of natural vegetables and proteins and carbohydrates and dates and mixed seeds and honey and all the good things, all blended and into his PEG. He has a clear daily meds, feeds and flushes timetable created by family. At the family request, he has an abdominal distension protocol in place to prevent hospital admission. For mobility and exercise, he stands daily in his standing frame for about 1 hour a day, hydrotherapy once a week, and a movement program 1 to 3 times a week. For his toilet positioning, routine and environment, he's hoisted onto a tilt-in space shower commode every morning for up to 30 minutes. 30 minutes might seem like a long time. However, we've had to adjust things to how he presents, and the way his poo comes out is in sometimes little bits at a time. So we've had to increase the time sitting to cater to his needs specifically. He actually stays in the bedroom as he's more relaxed watching TV than being in the bathroom where it's cooler and he's bored during that time. The recommendation for abdominal massage is once a day, same time, before sitting on the toilet or commode. But it's important that it works with the person with a learning disability's timetable and routine and the carers that support them. He does have laxatives, so regular Movicol and Prucalopride, and only PRN suppositories. So what I would like to say is there is a place for laxatives, and we are hoping to reduce the Prucalopride in the near future. And finally, he has a clear personalised constipation escalation care plan implemented by family, 24/7 care team, supported by the LD dietitian, LD physio, OT, GP, and gastroenterologist. And that's everything from me. I'll leave the take-home messages there for something that you can. I've summarised everything, I think, just so you have some time for questions. Thank you for listening, everyone.
Thanks, Ruksana. That was absolutely fantastic. I've learned so much, and I